Okay. Everything should be working. Okay. I am gonna do some maintenance shit while I'm live right now. Cool. Okay. Wonderful. Everything should be working. My throwables should be working. Everything should be working. Hopefully my audio isn't like blood curdlingly loud, like the background music, because like if it's my speaking, that's okay. I can handle that, and y'all better handle it too. Like, what else are you here for? You're here for me. You're here for me yapping. Like, what else are you supposed to be doing here? Okay. Cool. But yeah, welcome in everybody. I don't think anybody's here yet, but if people are, hello. Hopefully y'all are doing well. Streams are gonna be a little bit different. Oh god. OBS. What? Or not OBS. Figma. Everything in the background. Come on. I need you to cooperate, please. That would be very helpful. Oh my lordy loo. Okay. Cool. Welcome. So, streams are gonna go a little bit differently. I'm gonna be yapping a lot. I'm still gonna be doing Amboss. I'll be doing... Oh god. Oh my god. I hope my connection isn't like shit. Come on, stream. You can't be fucking doing this. Can't be fucking doing this. Come on. Okay. Because the destination should be good. The advanced options should be good. There should be low latency. I'm hoping for low latency today. No whammies. But okay. So, we're going to be doing a lot of talking, but we're first going to do just some warm-up Amboss first for our hypertensives, because that's the topic for today. Like, I have a whole schedule up now. Y'all should be proud of me. Like, so today for me is Wednesday. That's why stream starts at like 6 p.m. Philippine time / 5 a.m. EST. So yeah, Amboss and hypertensives. Then we're gonna go, Thursday is gonna be CVS Patho plus Amboss, and then CVS and viruses. So we're gonna do some warm-up first. I'm gonna make sure that everything is working on my end. And before we get into it, I'm just gonna do the fucking pre-rolls now, because I know that we have to. Mainly so that Twitch doesn't get on my fucking ass. So we're gonna do that first. Just before we get anything else done. So, I really appreciate if you guys stick around. Hopefully the ads aren't like fucking atrocious. I'm gonna do like a 3-minute one just so that we get it out of the way, and then, wait. Oh, I don't have to do anymore. That's fine. I don't have to do that anymore. Hopefully everything works. Okay, cool. We are gonna be starting in a second. I'm gonna pull up some Amboss questions for us. We're just gonna do some random Amboss. They might coincide with our sessions, they might not. We don't know until it happens. Okay, we are gonna be doing this session right the fuck now in 3, 2, 1. Okay. Oh god, wait, what the fuck? Come on. My Firefox should not be fucky like this, please. I'm begging you. There we go. That's better. Awesome. We're just gonna do some warm-up Amboss first to get our brains working. Oh my god, come on. My shit cannot be lagging this hard already. How dare they? Come on. There we go. Perfect. Okay, so we're going to do some warm-up Amboss first before we get started with anything else, and then we're going to go into CVS. We're going to go into we're going to go into hypertensive, so hypertension, just the overview. Then we're going to go into the management, so we're basically going to we're going to do an Amboss style where we go into we go into a summary of like what the fuck hypertension is, then the etiology, pathophysiology, that kind of shit, and then we're going to go into the management. That's what's happening today. And obviously, I'm yapping right now so that I get warmed up. And I really hope you guys didn't just hear my back crack. That would be embarrassing. But yeah, we're here. We're ready. And I should be good to start, I think. But okay, so, first question of the day. 4-year-old boy is brought to the physician because of a one-day history of passing small quantities of dark urine. 2 weeks ago, he had fever, abdominal pain, and bloody diarrhea for several days that was treated with oral antibiotics. Physical exam shows pale conjunctivitis and scleral icterus. So he's anemic. Scleral icterus, he's got pale. You know when you pull on your eyelids and you like look at the shit underneath? That shit's pale. His hemoglobin concentration is 7.5. We already see he's anemic. Platelet count is okay. Serum creatinine is 1.9. Peripheral blood smear shows irregular red blood cell fragments. Avoiding consumption of which of these foods would have most likely prevented this patient's condition? So, this is just my thought here. I have no clue what this is. Legitimately, I have no fucking clue what this is. We're just gonna click through and find out because, like, the only thing I can think of is, like, something with schistocytes, maybe? Or, like, that's what it looks like. But obviously, I don't know until we find out. So, because, like, for this would be serious. And that would be like, oh wait, bloody diarrhea. Shit, what thing causes bloody diarrhea? Bloody diarrhea. So, bloody diarrhea with foodborne illnesses, this could be a few things. It could be like shellfish, it could be, undercooked beef maybe, but like, the only thing that comes to mind right now is shellfish. I mean, raw pork would be like, if they have like weird neuro symptoms, because that's when you get like the weird the weird eggs in your brain. That's later though, but who knows? Maybe shellfish. Oh no, it's Shiga-like toxin. Oh my god, this is E. coli. Fuck. I didn't think about that at all. Oh, hemolytic uremic syndrome. Yeah, see, I would not have remembered. But yeah, so then that would be undercooked beef? Yeah, undercooked beef. Damn it. Oh well, now we know. I'm gonna mark this. That way I can redo that question later. Okay, 68-year-old man comes to the physician because of a 6-month history of difficulty swallowing pieces of meat and choking frequently during mealtimes. He sometimes regurgitates foul-smelling, undigested food particles. Accumulation of contrast and an outpouching of the posterior pharyngeal wall at the C5 level. Which of the following is the most likely underlying cause of this patient's condition? This is really familiar to me, and I'm trying to remember it. I don't think it's omphalomesoneric mesenteric duct, but like... Huh. What's the remnant of like the second branchial cleft again? Loki, I don't remember this. Scar fibrosis and traction of the esophagus. That's like seems the easiest, most likely, because like foul-smelling undigested food particles. He's 68. Maybe he has aspy pneumo. Accumulation of outpouching. Huh. Thyroglossal duct doesn't make sense. It could be... This could probably be scar tissue. Oh no! It is Zenker diverticulum. Fuck. That's one of these. That's this one. Damn it. That's on me, y'all. Like, I'm rusty right now. This is why we do this. We warm ourselves up first before we do anything else. This is what's gotta happen. Okay. Chronic fatigue and generalized weakness after exertion. Legs feel stiff. Okay. Leg cramps after walking up the stairs. Symptoms are always relieved by rest. Urine dipstick shows +3 blood, and UA is negative for RBC, so this could be rhabdomyolysis, because, like, if it's not RBCs, this could be myoglobin. Patient is asked to continually pump his arm. Oh. Serum ammonia increases. Lactate remains stable. Hi, Vulcan. How you doing, buddy? Okay. Biopsy of the right gastroc most likely shows which of the following. Also, we're not killing patients today. We're just doing mainly studying. We're just doing some Amboss questions to warm up. But how are you doing? Okay. This looks like... No, I don't think this is muscular dystrophy. Maybe... Oh, no. Oh, it's McArdle. Yeah, no, I didn't remember this at all. Yeah, I do not remember McArdle. Hell yeah, dude. I'm glad you're doing well. But okay. 53-year-old man comes to the physician for an annual checkup, diagnosed with Hep B. Which of the following is most likely to be found in the patient? Yeah, what's up? What up, buddy? So I think it is combined. But yeah, no, legit. What was your question? But okay. Low shows very low chance of infectivity. I don't know how to read this. Wait, aspartate. Okay, that's a little high, maybe? 1 minute, let me look at the labs. Oh, no, these are normal. Oh. Is she having a breathing tube? How long do you pass on injection with the sleeping tube for surgeries? So that depends. Also, hi Kai, how you doing? Thankfully, I'm glad it works. I checked it like 3 times today, but you pass out injected with the sleeping shit for surgeries. It depends on like the route of administration, low-key. That would be something for an anesthesiologist. I am not one. I do not know enough about anesthesia, but I can tell you it depends on the route. And also, like, you want them, like, this is just from what I've learned from just shadowing nurse anesthetists and anesthesiologists. They always say that you want them to go down fast, you want them to sleep fast, and then wake up fast. Like, you don't want them to be, you don't want it to last, like, super long after the surgery. What? Yes, see, there's more. I added more. Are you proud of me? Oh, wait. Oh, my God. It works on the chat. Let's go. Awesome. But okay, I do not know what this is, Loki. His AST is 19. ALT is 17. These are normal. But Hep B is detected. Load has very low rate of infectivity. Breathing tube? I don't know. I mean, that is a question. That's a question for someone that's had a breathing tube in. I've never had one. I wouldn't know. Okay, if it's serological findings, most likely to be found Hep B agglutination, maybe? Anti-Hep B. Loading says, what the fuck? I don't know how to read this. Oh, it was A. Presence of HB-CAG antibodies indicate either really recent or resolved Hep B infection. The combination of positive HBs, positive anti-Hep B, positive anti... Oh, I see. I get it. I think I get it. Yeah, I get it now. Hopefully. Okay, 55-year-old comes to the physician because of intermittent palpitations that occur when he's stressed, especially when he drinks alcohol. Carvedilol. Compared to treatment... Oh, this is an antiarrhythmic. Antiarrhythmic bullshit. One of the, he was given Carvedilol? That's... Oh my god, wait. This is for Carvedilol for, like, what? Stress, exercising. Okay, so intermittent palpitations. Adverse effects, so like weight loss. You can also have rebound hypertension. With the beta blocking shit with it, you can get dyspnea, bronchospasm, bradycardia, malaria, and asthenia. Huh. Contraindications, hypotension, maybe? I don't know. Oh, wait. Wait a second. Wait a second. What am I saying? You can have, like... Oh, wait. This is a beta... Fucking hell. I know what this is. Lightheadedness. So, like, vasodilation. The most prevalent is, like, undesired excessive hypotension. So it's, like, just hypotension. Yeah. I almost talked myself out of the wrong answer. This is why we read. Carvedilol. Yeah. This is AFib. Like AFib with RVR. Palpitations, irregular pulse, EKG, showing irregular QRS complexes and indiscernible P waves. But okay, let's continue. Carvedilol is a non-selective beta blocker with additional alpha blocking action, which is why it also does the excessive hypotension. But okay, ED after sudden onset of speech difficulties. Ooh, 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 ooh. I mean, he got like paresthesia. Oh, wait, paralysis and hypoesthesia on the left side, Babinski sign on the right, and slurred speech. Hyperdensity on the left, no evidence of intracranial bleeding. Given. I think this is heparin. Oh no, it's alteplase. Fuck, that was my second option. Alteplase is a recombinant tissue TPA. I didn't think about it. Okay. Because, like, this is also used in STEMI. That's the problem. I just didn't think about the acute ischemic stroke. And this is why we're going to go over ischemics today as well. But okay. 3-year-old boy. Tonic-clonic seizure. Hepatocytes. Enzymes are located at the cytosol of hepatocytes. Okay. Which are the following labeled enzymes? So... I think it's arginine. Wait. I think it's arginine. I could be wrong. Oh, wait. So, B. Oh. So D. Oh, no. Urea cycle disorder. Is it E? It was E. It was like D or E for me. I was like D or E. Because, like, oh man, that's fine. Okay. Otherwise healthy 25-year-old comes to the physician because of a 2-day history of pain and swelling in her right knee and left wrist. Camping with her new boyfriend 3 weeks ago, but does not recall any tick bites. Oh. What do we think about this, you guys? Tender pustule on the sole of the left foot. So... Oh. This looks like it's like reactive arthritis, maybe? Is that the thing? Is that the thing that, like... So it's... Oh, no. Really? Huh? I would not have thought gonorrhea. Oh my god. Intracellular organisms. Okay. Fucking hell. Fine. Okay. 72-year-old man comes to the physician for a routine physical exam. Felt well, except for occasional headaches. No history of major illnesses. Or major medical illness. Right kidney, normal right kidney, and a left kidney that's 2 centimeters smaller in length. I I think this is gonna be elevated urine metanephrine. Oh, no. Oh my god. What is it? Abdominal break. Fucking hell. Oh well. Yeah, we're gonna go on to hypotension. We're gonna go on to hypertension now. We're gonna yap about that because at least that I understand. These are pissing me off. Okay, we are gonna go on to that 1 minute. I'm putting on the marker, hypertension yapping, and we are gonna open this up. And okay, so I'm putting myself a little bit more to the corner, that way we can see it a little better. Because I'm gonna be drawing this shit out. We're gonna be talking about all this shit. But okay, so hypertension management. How do I open this up? My god. Okay, where's my tablet? Fuck, did I put my tablet away? Found it. I am okay. I'm okay. Cool. So we're gonna go on to hypertension. So, what the fuck is hypertension, firstly? Like, we already kind of know what this is. Hypertension is it's extremely common both here in the United States and in the Philippines and, like, everywhere fucking else. Hypertension is basically so there are multiple different criteria for what is hypertension. So, we're gonna... a minute. Okay. Okay, so HTN, hypertension. What the fuck is this? Basically, hypertension is a common condition that just kind of fucking happens everywhere, really, low-key. And it in the United States, it affects like fucking one in every 3 adults, and it's extremely prevalent. It's getting prevalent among children. Oh my god, I should like actually write this properly. And it's becoming more prevalent in children, so... What is I doing? The definition of hypertension in adults is a blood pressure of greater than 130/80, according to the AHA guidelines. So I'm going to put this here. AHAHTN equals greater than 130/80. That's according to the AHA. The JNC8 is 140/90. And these are in adults. These are all happening in adults, by the way. Hypertension can be classified as either primary, also known as essential, or secondary. So... secondary, basically due to something else. And usually primary hypertension accounts for like 90% cases of hypertension and has no detectable cause. So... okay. Hopefully y'all are getting it. Hopefully y'all are getting what I mean here. Hopefully my handwriting isn't too shitty. Oh wait, I'm gonna make this like other due to other cause. Due to other cause. So I'm gonna keep yapping now. Typical underlying conditions for secondary hypertension are gonna be shit that goes on in your kidneys. So I'm gonna draw a kidney here. Kidney. Kidney. That's a kidney to me. Endocrine issues, so like shit that goes on in the adrenals. So that's how I'm gonna draw my adrenals up here. Yeah, kidney. Hi, Molar. How you doing, buddy? You usually hang out in Red Stream. I appreciate you being here, though. Kidney, so like renal failure, endocrine issues, vascular diseases. So like renal failure, primary hyperaldosteronism, and or coarctation of the aorta. Clinically, hypertension is usually asymptomatic until organ damage occurs with the brain, heart, kidneys, or eyes. So retinopathy, MI, or myocardial infarction, or stroke. Those are what's most commonly affected. If present, oh, cool, hell yeah, man. If present, early symptoms of hypertension may include headache, dizziness, tinnitus, or chest comfort. Ah, I see. I hope you enjoy me yapping about hypertension. I know this is probably shit you've already heard before, but like, I mean, I'm already talking about it because I have to for class. So, that's what we're doing this. What were they saying? So it's asymptomatic until organ damage occurs with the heart, kidney, brain, or eyes. So if you have retinopathy, myocardial infarction, stroke, those are most commonly affected. Early symptoms of hypertension may include. I'm gonna delete like all of this now. Early symptoms. EARLYSX HA or headache, dizziness, tinnitus, chest discomfort. And it is suspected if in-office blood pressure is persistently elevated on 2 or more measurements and is confirmed with out-of-office measurement. Further diagnostic measures include assessment of cardiovascular risk, evaluation of possible organ damage through like kidney function tests and shit, and like additional tests if like an underlying disease is suspected. So like if this is primary or if this is secondary. Treatment of primary is going to include sorry, ADHD moment, y'all. Right. I'm back to it, y'all. Sorry about that. Treatment of primary hypertension is gonna include, so I'm gonna put like TX is gonna be lifestyle change. Lifestyle delta. Delta means change. Here I always use delta. And meds. We're gonna go into the meds after, but like this is just the main thing. We're just going overview right now. Commonly prescribed antihypertensive medications are going to be ACE inhibitors, angiotensin receptor blockers, or ARBs. So I'm going to put this under here. ACE, ARBs, thiazides, CCBs, or calcium channel blockers. I think we talked about this on Sketchy, we watched the Sketchy on this, like, I don't fucking know, Monday or something. I don't remember anymore, honestly. I am so tired. Pharmacological management of pediatric and pregnant patients do differ, as some of these meds are not recommended. They're actually contraindicated in those patient populations. But for secondary hypertension, it's going to be treatment of the underlying issue. So this is for primary, TX for secondary. Fix the issue. Because if you fix the issue, you're not going to have the hypertension anymore. Obviously. But, so, I already talked about the definition in adults, but I did not talk about the definition in children. So, I kind of mentioned the shit about children, but you guys still remember the hypertension in adults things like the JCA, like the ACA or the AHA plus the JNC8. So AHA is 130 over 80. Like if you have a blood pressure greater than 130 over 80, JNC8 is going to be 140 over 90. But in children, the hypertension in children, for those that are less than 13 years of age, basically if your blood pressure is greater or equal to that of the 95th percentile, or just greater than 130 over 80, whichever is lower. For greater than 13 years of age, that's when you like use the adult measurements. That's when it's like over. That's when your blood pressure is over 130 over 80. Primary hypertension, I already mentioned, it's going to be hypertension with no identifiable cause. For secondary hypertension, this is by an identifiable underlying cause. And resistant hypertension, we already know this, that's hypertension that remains uncontrolled despite treatment with 3 antihypertensives or requires like greater than 4 meds to be controlled. So, okay, I'm going to put like, so, kid. So if they're 13 or less, that's going to be 130 over 80 or 95th percentile. Greater than 13 is going to be 130 over 80. For primary, you already know, and resistant is going to be greater or equal to 130 over 80 without change with 3 meds or needs 4 meds to positively fix. That's why there's a delta with a check mark. My shorthand will make sense. I promise. I promise it'll make sense to you, like, once I keep doing this. You just have to keep listening to it. But okay. So, I'm going to put the table up here from Amboss. That way we just have it. So, oh no. So, HTN. And the table. Here is our table. There's also a third guideline that we have to like think about, but they didn't really mention it. So I'm not really caring about it. Oh, wait. I hope y'all can see that. I really hope y'all can see that. I'll make it bigger. Hi, how you doing, buddy? We're talking about hypertension because I forgot everything from lecture. We already know about the prevalence of hypertension. It's like approximately 1/3 and 1/2 of the adults in the United States. I do not remember what it is for the Philippines, but it's a lot. Let's go. Okay. And for primary hypertension, that's like greater than 90% of cases of hypertension in adults, and the prevalence is increasing in children and adolescents. Secondary hypertension is like the rest percentage, so like around 10% in hypertension in adults. And the prevalence increases with age. So like approximately 65 to 75% of adults develop hypertension by ages 65 to 74. So the percentages kind of match with their with their ages, basically. kind of, I would say so at least. But okay. And for sex, it's going to be greater in men than in women if they are like less than 65 years of age. So the distribution is like after menopause, the prevalence increases in women to like Yeah, at greater than 75% of age, the prevalence is higher in women than men. So I really hope y'all are understanding what I'm writing here. Fucking hell. But so the etiology of primary hypertension, so like this is a lot of shit going on. But it is basically directly related to protoperipheral resistance and the cardiac output. So let's go to 1. PR plus CO. I'm just using the abbreviations because I already said what they are. PR is total, or TPR, I should put TPR. Total peripheral resistance, and CO is the cardiac output. But there are also risk factors associated with it. So the risk factors for primary hypertension, I'm going to go into the non-modifiable ones first. The non-modifiable ones are the things that you're born with, basically. So like positive family history, advanced, or the things that you can't really change. Positive family history, your race and ethnicity, and advanced age. So like you can't really go back if you're getting older. Unfortunately. Wish I could. God, I'm so fucking old. So I'm gonna change that to be a positive FHX. So we, in the States, we have to care about race and ethnicity a lot, but like in the Philippines, we don't really have to because most people are just Filipino. But like we still have to care about it. Though obviously it's more on the nutrition and diet versus like just straight race and ethnicity. So that's like where we really have to think about it. Like what I do want to know, like what goes in to why race and ethnicity matter in terms of like hypertension. I want to talk to like Psychen about that eventually and like just ask him, be like, hey, how much do we have to care about race and ethnicity now? Because like it's happening to everybody. But okay, the modifiable risk factors, so the shit we can change. So that's gonna be wait. DM. Wait, there we go. Smoking. Alcohol. High diets high in potassium and low in sodium. Physical inactivity and stress. I'm drawing a couch for this because it's like you're a couch potato. I hope you get the picture that I am putting in your head here. I hope we understand what's going on. But okay, and psychological stress. So like I'm just gonna put a frowny face because you're not happy when you're stressed. Like that. That's for primary hypertension. I hope we understand what I'm getting at here. I hope like my like little drawings and shit are comprehensible. If they're not, let me know. I will answer questions I will answer questions to the best of my ability. Like regarding this topic. But okay, so the clinical features, I already kind of mentioned that hypertension is asymptomatic until you get complications happening, like if you have end organ damage or if you have an acute rise in blood pressure. So like a hypertensive crisis or like, oh my God. Okay, so like if you have an acute hypertensive crisis, that kind of shit. But there are non-specific symptoms of hypertension. I already kind of mentioned them. So like if you have headaches, especially early morning or waking headaches, dizziness, tinnitus, or blurred vision, if you're like always flushed, you have nosebleeds. You have chest discomfort or palpitations. You have strong bounding pulse on palpation. Like whenever you like palpate a patient and you feel like their pulse is I mean basically like you can feel it bounce back. Like you can literally feel it smack if you feel it and it's like really strong, like really really strong. I don't really know how to explain it. Like I can feel the difference. Bro. Like, I can feel the difference. Y'all are just gonna have to, like, work on that. Like, I think we can find patients. Honestly, like, I think a lot of our classmates have hypertension. Like, we could just ask to palpate them. I'm joking, I promise. Imagine, like, getting diagnosed by your classmate being like, hey, you have hypertension because I palpated your pulse and it was, like, really bad. And you're, like, always flushed and you have dizziness and blurred vision and headaches. But yeah, so nervousness, fatigue, and sleep disturbances. Also, fatigue and sleep issues are gonna increase your risk of getting hypertension. And also, like, a lot of other shit. So, like, don't do what I do. Y'all need to sleep. Y'all need to sleep. Though I understand, we're in medicine. What can we do? We have to, like, do well. But okay, there's also some different subtypes and variants. So mask type, so like when we look at hypertension, I'm going to go into secondary after, but I'm going to look at specifically different kinds of hypertension that just kind of happen. So there's two kinds for this. So like this is something I saw a lot in the clinic. Like I would see this happen. Like I would take their blood pressure in the clinic, but like if I took their blood pressure but if they came in with their blood pressure readings and they were done by like their nurse daughter, they would be consistently low. But when they're in the clinic, it's always high, like crazy high. And they don't have hypertension. This is white coat. So white coat and masked hypertension can be distinguished by either ambulatory blood pressure readings or home blood pressure monitoring. So, like, I don't know how accurate this is, but, like, it seems like a lot of watches, like a lot of these smart watches nowadays, they can check your blood pressure. I mean, I know mine does. But, like, you can use readings like those to test to see, like, how their blood pressure is at home compared to the readings that we get in office. But, I'm gonna take a screenshot of this table and I'm gonna put it in. So, oh god, I always forget this is so small. But okay, so like interpretation of blood pressure readings. For sustained hypertension, in-office blood pressure will be elevated and out of blood pressure will be elevated. This is what we're usually going to see. This is what is expected. But the other two are what's not really expected. White coat is isolated clinic hypertension, where it's elevated in office but normal out of office. Masked hypertension is where it's the opposite, isolated ambulatory hypertension, so normal in office but elevated outside of the office. Don't ask me why this happens. Like, according to Amboss and like a lot of other sources, it's like primarily due to stress and anxiety combined with being in a medical environment, because medical environments can make you nervous, which I understand. I get it. You don't want to be there. Nobody that's healthy, unless they're like rich and like able to go like weekly, or not weekly, oh my god, but like every 6 months to the doctor and be able to sustain that, is going to the doctor happy. They're not having a good time there at the doctor's. Now, let me tell you. Nobody likes going to the doctor. Even me. I don't like going to my doctor, even though like I worked with him, so like I couldn't really escape him. Though that kind of added to it, not gonna lie. But yeah, so you gotta confirm the true elevation of the in-office blood pressure measurements. So you take different blood pressure measurements several minutes apart after the patient has had time to relax. So you would also continue, I would consider screening using like daytime ambulatory blood pressure monitoring or at home blood pressure monitoring in patients that have like super high blood pressures, like super high in office blood pressures. So, like if the in office blood pressure is like greater than 130/89, but less than 160/100 after like, say they do have hypertension, but like it gets worse in office versus outside. Diagnosis of white coat hypertension is confirmed in patients with in-office readings that's greater than 130/89 and less than 160/100, and out-of-office readings that are less than 130/80. Management, you're just gonna have to it's the same thing. You can continue, it's like pretty non-invasive, no meds. You don't even take meds for it. You just have to continue lifestyle changes for managing the hypertension, but this is for white coat. For masked hypertension, the one where it's like you're normal in office but weird outside of office, you're going to still continue the lifestyle changes, but you're also going to start pharmacological treatment of the hypertension, and you're going to keep doing the ambulatory or the home blood pressure monitoring annually. Because patients with masked hypertension have similar risk of stroke, cardiovascular disease, and all-cause mortality to those with sustained hypertension. With like, yeah. And then, but yeah, so I yapped a lot about that. We're going to go on to secondary hypertension. Also, if I'm going too fast or you have any questions, please let me know. I do not want to leave anybody behind because I'm just yapping away. Okay, so for secondary hypertension. So basically, the things about secondary hypertension are that they're a little weird. So, you got severe hypertension, which is going to be resistant hypertension, which is the kind where, nothing gets better. The hypertension doesn't improve even with like the addition of like 3 meds, or it needs like more than 4 meds to be normal. You know what I mean? I mean, you know what I mean, chat? Yeah. But also for secondary hypertension, for the severe hypertension subtype, you're gonna have target organ damage that is disproportionate to the degree of hypertension. So a patient, like an example, a patient with stage 1 hypertension, but they have severe they have severe CKD or chronic kidney disease. That is disproportionate. We're not supposed to expect that whenever we see patients with class 1 with stage 1 hypertension. So 2 subtypes here. So we have severe, and we also have unusual. We have resistant. We have emergency. I'm just gonna do that, emerge. And then we also have organ damage. Greater than HTN stage. But yeah, this stuff is just stuff that we're gonna be seeing a lot, especially because like hypertension is just gonna be the thing that we're doing today. Unusual onset of hypertension is also weird. It's all weird. That's all I'm gonna say here. It's all fucking weird. So, unusual onset. This can be abrupt. So, like really sudden. It can also be like, you get it when you're less than 30 years of age. That is not normal. That would be considered an unusual onset of hypertension. Because when you're less than 30, that's like supposed to be the peak of your fucking life. You're not supposed to be getting that kind of shit. That's not good, obviously. Or if you have, like, say, like if you have just hypertension at less than 30 years of age, or if you have diastolic hypertension at greater than 65, or exacerbation, like if your previously controlled hypertension gets worse. Exacerbation of previously controlled hypertension. That's not supposed to happen. It's supposed to be well controlled. Or it could be drug-induced hypertension. So, like, let's say you take some psychostimulants. Your blood pressure is gonna increase. If it increases up to the degree where it's like greater than the hypertensive like guidelines, that's a drug-induced hypertension. Obviously, that's not good. Or you have like unprovoked or significant hypokalemia. Yeah, don't worry. I am gonna drink water in a second. I promise. Where the? Oh my god. Y'all, I am gonna crash out. My protein shake is still frozen. I'm gonna get water. Ugh. Cannot believe. 2 seconds. Oh my god. My water containers are so hard to open. What the fuck? Okay. I am back. Okay. But yeah, so also do not mind my handwriting. It is terrible. It will always be terrible. I live up to the stereotype. What can I say? Okay, so it's going to be less than, if you have an onset of less than 30, or if you have diastolic HDN, hypertension at greater than 65 years of age. So I'm going to write that in here as well. Drug-induced. Also, unprovoked or significant hypokalemia. But yeah, that's what we're looking at here. So, the causes of secondary hypertension, the ones that are most common in, like... Oh, no. No! Wait! Did I accidentally draw on my... Oh, thank God I didn't draw on the grid lines. I do not like drawing on the grid lines. I like having my grid lines there. But okay, so... Oh no, my tablet is lagging. How dare you. Come on. Okay, perfect. So, the most common causes in adults include... Oh, yeah, you can literally see my tablet lagging. Oh my god. Okay. Common causes. Common causes are going to be if you're less than 40. Oh my god. I know my tablet isn't, like, dying on me. God. What the hell? It is a good tablet, too. Less than 40. Why? Oh. Okay. For less than 40 years old, this is going to be thyroid dysfunction, fibromuscular dysplasia, and renal parenchymal disease. If you're 40 to 64, that's now you're going to have hyperaldosteronism. So you're still going to have endocrine disorders going on. But you're also going to have obstructive sleep apnea. That is a very common cause of secondary hypertension. And to fix the hypertension, remember, In secondary hypertension, you fix the underlying cause. And if you're greater than like 64 years old, it's going to be renal artery stenosis. So DFX, that's just my little shorthand for dysfunction. So this is going to be OSA. Thyroid dysfunction and hyperaldosteronism. Hyperaldosteron. And if you're greater than 65, renal artery stenosis. Renal artery stenosis. Okay, cool. The most common causes in children and adolescents, though, include coarctation of the aorta and renal parenchymal disease. But also, this is a stat quote for everybody. Young adults with young adults, so especially women that's less than 40 years of age, with suspected secondary hypertension should be assessed for renal artery stenosis caused by fibromuscular dysplasia. So, I am gonna put this on screen. These are the causes for, secondary hypertension. These are the most common. So, this is gonna be through a mnemonic called recent. Oh no. Oh my god. Why does this keep happening? There we go. Okay, recent. R E C E N T. I'm gonna lock that, make it a different color. And so this is gonna be renal. Oh, what the hell? What happening? Okay, right, what was I saying? Right, recent, so renal. The fuck, come on. There you go. Renal, endocrine. Coarctation of aorta. The coarctation of the aorta. Neurological. Oh, wait. Oh, estrogen. Neurological would be like still drug induced. So like, say you're taking psychostimulants, say you have raised intracranial pressure. That would be under neuro. And treatment, that would be like drug induced. So like if you're taking glucocorticoids or NSAIDs. Treatment. Cool. And so that's the main thing. So for renal hypertension, that's going to be renal artery stenosis, chronic kidney disease, or renal parenchymal disease due to glomerulonephritis, polycystic kidney disease, systemic lupus erythematosus, renal tumors, and atrophic kidney. Like if your kidney was just not really developed. Atrophic kidney is a decrease in tissue mass, so it can be caused by a decrease in cell size due to cytoskeletal degradation or decrease in protein synthesis, or decrease in the cell number in the kidney. Basically, if your kidney goes through atrophy, that's going to be a renal cause. That's going to be a renal cause for renal hypertension. For endocrine, that can be a pheochromocytoma. That could be Conn syndrome. It could be hypercortisolism or Cushing's. It could be hyperthyroidism. It could be primary hyperparathyroidism. It could be congenital adrenal hyperplasia, or it could be acromegaly. Acromegaly due to like increased serum insulin growth factor 1. But also, important thing, it's not necessary to stop a patient's antihypertensive meds prior to testing for primary hyperaldosteronism. And now we're going to go into coarctation of the aorta. That would be, coarctation of the aorta is a congenital heart defect that involves narrowing of the aorta just distal to the left subclavian artery, or less commonly, narrowing of the descending thoracic or abdominal aorta. Manifestations often include upper extremity hypertension and weak femoral pulses. This is frequently associated with other congenital heart defects like a bicuspid aortic valve, ventral septal defect, patent ductus arteriosus, or Turner syndrome. Now we're gonna go for coarctation. You can, for workup for that's gonna be a Doppler, an echo Doppler. You can do an X-ray of the chest, or you can do a CTA, a CT angiogram, or MRA of the chest and the abdomen. For the next one, I'm going to talk about obstructive sleep apnea, because I mentioned it earlier. Basically, this is because the pathophysiology for OSA is just the fact that, you know how sleep apnea works, right? Like, if you've never had it, you've probably heard it, or you know somebody that has it. When someone has it, whenever they sleep, there are periods of time whenever they sleep that they go into like apneic phases. This means like they stop breathing for a little bit. It's like the and then they like go back to like snoring again. Like they're like really like gnarly sounding pauses during their breathing while they're sleeping because they are choking on their tongue. And that would be a cause of secondary hypertension. The pathophysiology here is that there's going to be increased catecholamines during the apneic phase of like when they're sleeping. It's like when they're choking, there's increased catecholamines, and when there's increased catecholamines, you're going to be getting secondary hypertension. Indications for workup for this would be obesity, snoring, or daytime sleepiness. But there also could be a non-dipping pattern on like 24-hour blood pressure monitoring. So what I mean by that is, so like when you're asleep, did you know that your blood pressure drops? Like, obviously, common sense wise, yes, it makes sense that your blood pressure would drop when you're asleep. Because like you're not really doing anything. You're obviously not really doing anything. There's no reason for your blood pressure to be raised. But if you have OSA, you will not be having that dip on your blood pressure monitoring. And they can see this during sleep studies. Oh my god, wait. Sorry, I'm checking, you guys. I'm just checking something. I got an announcement. Oh, let's go. Oh my god, so it's just one auditorium tomorrow. Amazing. Love that. I don't have to worry about anything. I don't have to worry about being there on time, etc., etc. I don't have to worry about going to the wrong auditorium because it's all one auditorium. Lovely, because that happens to me a lot. Like, sorry, let me digress. Sometimes whenever I go to class, I don't really check which auditorium I go to. Yeah, absolutely. Yes, please. Sit with us in front. Oh my god. Please. Please, please, please. It'll be fun. But yeah. Oh my god, what was I saying? Oh right, OSA. So obesity, snoring, or daytime sleepiness. And you have a non-dipping pattern on like blood pressure monitoring. Because like when you're asleep, usually you're gonna have a 10% dip in your blood pressure. But if you have OSA, you're not gonna be seeing that dip. And you're gonna be seeing that on a sleep study. And sleep studies will often result to the resolution of the hypertension because you're having a CPAP. Oh, girl, the reason why I sit in front is because I'm fucking blind. And do you think I remember my glasses? No, I never remember my glasses. I literally, I will admit this today. I can't find my glasses. I can't find them. They're somewhere in my dorm, but I can't really find them. Like I don't know. I'm very clumsy. I lose things in my own room. And like my dorm isn't even that big. It's just a studio. It's not even a full, it's a one room. I don't know how I lose things in here, but I do. Don't ask me why that happens. It just does. It's just a fact of life for me. I lose things. But yeah, so next part is going to be substance related secondary hypertension. So for this is going to be drug use, maybe caffeine. So like this is going to be recreational drug use, like maybe amphetamines, cocaine, phencyclidine. I don't know the slang term for phencyclidine, but it's like, oh, yes, I do. Phencyclidine is angel dust. Cocaine is cocaine. Amphetamines are like meth. Also, caffeine, nicotine, and or drug use. All of these things can also cause you to have secondary hypertension. Also, use of certain medications like sympathomimetic drugs, like decongestants. So, like, oh my god, sympathomimetics. Like phenylephrine, like those decongestants, or like, yeah, phenylephrine can do it. Phenylephrine can also make you have high blood pressure. Also, corticosteroids can do it, NSAIDs, and oral contraceptives. The workup for those are going to be urine drug screening and like if your blood pressure improves when you like remove the medication from the patient. And management of secondary hypertension depends on the suspected cause. But now we're going to go into screening for hypertension. I don't know. Do we need to know about screening? Do we need to know about screening yet or no? Like, I don't remember. Because, like, I kind of just keep yapping. And I will just continue to keep yapping unless someone tells me, hey, you don't need to yap about that. So, until I get a confirmation, I'm going to keep talking. But okay, I'm gonna continue. So, for screening for hypertension, I'm just gonna keep going. So, screening. Oh my god. Come on. Come on. My god. S C R E E. Oh my god. I do know how to write, you guys. My tablet is just lagging a lot for some reason. I know how to write. My handwriting is not terrible. I promise. Well, that's a lie. My handwriting is terrible, but I'm not doing this on purpose. I'm like trying really hard to make this legible. Screening. Okay. So there's annual. Oh my god, my handwriting is ass. Holy shit. But okay, so for annual screening, this is going to be for adults of any age with risk factors for primary hypertension. Oh my god. RISKF. I don't really know what to say, except I am sorry. My handwriting is not this bad. This is my tablet is rioting against me. But okay. So for adults greater than 40 years of age, or with any age, or adults of any age with risk factors for primary hypertension, and it's going to be through in-house blood pressure measurement. And if it's elevated, the measurement should be repeated on both arms. Elevated blood pressure measurements on at least 2 readings obtained at least 2 separate visits will support the diagnosis of hypertension. Oh, also, fun fact, 20% of individuals with high blood pressure are unaware they have hypertension. Have you gotten screened today? Have you gotten screened yet? I would recommend you maybe get screened. That's just me. So that you know what you know. That's all I'm saying. Like, if you're worried about like blood pressure shit, maybe you should go talk to your doctor and be like, hey, I got like weird symptoms going on. I want to talk to you about like maybe getting screened for it. And I mean, they do blood pressures like at every visit anyways. Like they will always do vitals. They always do vitals. So it won't be hard. You can get screened. It's important. It's good for you. It's good for you. It's good for you. Okay. But for diagnostic confirmation, out-of-office measurement is recommended in all individuals for confirmation of hypertension before you like initially get treated. So ambulatory blood pressure measurement is the preferred method, and that's basically a device that measures blood pressure at fixed intervals over like 12 to 24 hours. Or you can do like home blood pressure monitoring, where you do the blood pressure measurements yourself at home at periodic intervals. Also, the routine studies for evaluating patients with newly diagnosed hypertension will be obviously physical exam and history. But for the routine studies, it's going to be like a fasting glucose, serum, sodium, potassium, and calcium levels, renal function tests, so your serum creatinine and EGFR, your complete blood count, your TSH, your lipid profile, your urinalysis and urine albumin to creatinine ratio, and ECG. You may also, like, if the history needs it, or if other stuff like indicates, hey, maybe we should get these tests done, you can also do an A1C, liver chemistry, so like liver function tests. You can also do a serum uric acid or maybe an echo. Now we're going to go on to management. We're going to go on to management in a second. I need to drink some water. Oh my god, one sec. Oh my god, okay. Okay, I really hope my tablet is going to cooperate with me right now. Man. Nudge. Mint. Oh my god, that is beautiful. Look at how nice that is. Amazing. You can read it finally. Okay, so. Bro, I don't know why everything is happening. But yes, absolutely. Crash Out Crew for YO3. We're gonna make it. We're gonna fucking make it. Because if we don't make it, I'm gonna freak out. We have to. We have to fucking make it. We have to make it. There is no other choice. What the fuck are we supposed to do? But yeah, so for management, obviously we're going to encourage lifestyle changes. So first set. So it's going to be like a 1-2 punch. So Change. You're welcome. That's the point. It's supposed to, for me, it's supposed to be comedic, and for you, exactly. You get it. You get it. Okay, so lifestyle changes. So basically, we're going to do weight loss. Oh my god. Wait. Oh my god. Weight loss. Next. So we're going to try and get them down to their ideal body weight. I was not born yesterday, buddy. I know what happens. I know. I know what's going to happen if I say that. I am smarter. But okay, so for weight loss, and then for diet, there's a few things for diet. So, like, the most effective shit is gonna be the DASH diet, where you're gonna have, like, a minute. Oh my god! Fucking cooperate, tablet! You know what? I think that's gonna be on the throne now. A new fucking tablet. Oh my god! Why is my tablet not cooperating? I know you can work. I've drawn with you before. The DASH diet. This is gonna be the most effective. The DASH diet, you're gonna like... So the expected change in your blood pressure is like the expected reduction in your blood pressure in hypertensive patients. This can be like 11 points lower. So like minus 11 mmHg. For this, it's gonna be... I don't know if they're gonna ask this, but they might. I don't know. This is just the stuff that's high yield. This is just the stuff that's important for us to just know. So there's gonna be 1 G per minus kg. So basically, for every kilogram reduction in body weight, there's gonna be minus 1 point off of your blood pressure. That's the expected. That is the approximate reduction in hypertensive patients. This is an approximation. It's not exact. The next one is to increase dietary potassium. So like if your dietary potassium intake is like 3.5 to 5 grams by increasing fruit and vegetables, it's going to be less effective than like reducing dietary sodium or doing the DASH diet, but it's going to be good. And then you're going to do also increasing aerobic for exercise. So aerobic exercise, aerobics, resistance training, isometric resistance training, like hand grip exercises or like weight training. Also extremely effective. They're effective on their own, but like everything will like be even more poggers if you do all 3 of these things together. So like exercise, diet, and weight loss. All of these 3 things are going to be pog. Also, smoking cessation should be advised in all patients to reduce their risk of like atherosclerotic cardiovascular events. That's going to be extremely important. But also, when we do these things and when we recognize ways to like help our patients in their hypertension management, we need to like consider why they're having this high blood pressure. Like, is it stress? Is it anxiety? Is it lack of access to fresh food? And then that's when you make like appropriate changes or appropriate referrals where necessary. So like, I don't know. Okay, question. In the Philippines, do we have anything like social work or like any food programs or nor? Like, do we have anything like that? Because like in the States we sometimes do. Like, I mean, we had food stamps. We had food stamps. I don't know if we still do, low-key. But if we do, like, you can use things like that. You can refer them up to, like, Meals on Wheels. I don't know how good Meals on Wheels is, but that's another option. Meals on Wheels is specifically a United States thing, and it was for, like, elderly seniors, I think. Yeah, this is for the seniors and elderly. Yep, I just remembered. But also, another important thing, do not recommend increasing your potassium intake, or do not recommend increasing potassium intake in patients with advanced CKD. Don't do that. Everything else should be done. But do not increase the potassium intake, please. That's bad. It's not gonna do well for them. It's not gonna be great. And now we're gonna go on to the management with medication. So, this is gonna be a pain. Okay, so med management towel. Med management. So, okay, so choices of initial medication should be based on like their initial blood pressure, maybe their major comorbidities, their major contraindications, and adverse effects that may be unacceptable to the patients. So for the first line options, we kind of already know what these medications are. So we're going to look at the ACEs. If my tablet pen will allow me to draw this out. ACE I. So ACE inhibitors, these are the motherfuckers that end in pril. So what these motherfuckers do is ACE inhibitors. These are a group of antihypertensive medications that inhibit the enzyme responsible for the conversion of angiotensin 1 to 2. Other uses include the slowing of the progress of CKD, delaying the onset of nephropathy in patients with DM, and treatment of like left ventricular systolic dysfunction. And those are the motherfuckers that end in pril. So like lisinopril, enalapril, captopril. I'm pretty sure there are more prils, but I do not remember them right now. Let's look at some names. Oh, Benazepril. Do we still use that actually? Oh my god, where's Psychic when I need him? Actually, where's Rico when I need him? Like, I could ask him too. Oh well, I don't know. He's probably working or asleep. But okay, so ACE inhibitors are going to be like benazepril or latensin, captopril, benzapril, enalapril, captopril, fosinapril, lisinopril, moexapril, quinapril, ramipril, and there are some others. I already mentioned what they're used for, but ACE inhibitors are not good if you are pregnant. They have been linked to birth defects in babies. If you're pregnant or planning on becoming pregnant, do not. No. There are other alternatives. Ask your doctor about them, obviously. And the other alternatives we're going to talk about. But like ACE inhibitors are indicated because they are nephroprotective, and they are preferred in patients with diabetes mellitus, and albuminuria, and renal disease. ARBs are the ones that end in sartan, or artin. So ARB. These are the angiotensin receptor blockers. So, oh my god. Okay, ARBs. These are the ones that block angiotensin 1 receptors, which decrease the binding of angiotensin 2. ACE inhibitors inhibit the conversion of angiotensin to angiotensin 2. but the ARB inhibitors or the ARB blockers decrease the binding. This decreases vasoconstriction, which lowers blood pressure, and also leads to decreased secretion of aldosterone, which also decreases the resorption of sodium and then water, and also lowers blood pressure. Angiotensin, the angiotensin receptor blockers, the ARBs, are like valsartan, irbesartan, losartan, and candesartan. I actually took candesartan for migraines for a little bit. It didn't really work as well because like mine aren't like hypertension based. That's what like, but like that's what you get put on first because that's what you have to be put on first. I guess I don't fucking know. But okay. But yeah, these are good for this. They have the same indications as ACE inhibitors, as in they're nephroprotective, so they're good for patients with diabetes mellitus and renal disease. Next, we're going to go on to the thiazide. So these are the ones that end in thiazide, usually, or unless you're talking about chlorthalidone. Chlorthalidone is a thiazide diuretic, even though it doesn't sound like it. I think the prototypical one is hydrochlorothiazide. I think so. Yes, it is. Yes, it is. A thiazide diuretic inhibits the sodium and chloride resorption in the DCT. So, if you were hoping that you would be free of the loop of like the fucking the nephron, you're never gonna be free ever. You are never free of the nephron. You know what? I'm gonna look for like a picture of the nephron with like. I'm gonna look for a picture of the nephron with like the interactions, like the nephron interactions with like meds, so that we can see. Here we go. Come on, let me see the. Oh my god, ResearchGate, you fucking cuck! How dare you? ResearchGate always like tries. ResearchGate always pisses me off. Oh well. But I found a picture. So these are the thiazides. I'm gonna put this right here. Oh yikes. This is so small. Oh god, this is for fucking ants. Oh my god. Actually, I mean, I think this should be okay. Is this still visible for you guys? Can you see it? I can increase the size of the Clip Studio Paint that way, like, you can see it a little better. Give me 2 seconds. How's that? Is this better? Is this better, you guys? Can you see it a little better? But yeah, so these are the thiazides over here. So hydrochlorothiazide, and it acts here on the distal collecting tubule, on the DCT. Or collecting, oh my god, no, not collecting, oh my god, convoluted, on the distal convoluted tubule, sorry. Convoluted. Convoluted tubule, it's the convoluted tubule. This is the collecting tubule, sorry. Not the other one, not the other one, but yeah. So a thiazide diuretic inhibits sodium and potassium resorption in the distal convoluted tubule. It's used to treat hypertension, chronic edema, and renal diabetes insipidus, and it's also used to prevent calcium kidney stones. Yeah, so hopefully that helps you guys. And then we're gonna go on to our loop diuretics. Oh wait, I didn't even go into the next part, so 1 second. But these are the thiazides. These are your convoluted tubule. We're gonna go. The loop diuretics are second line, and they act on the your loop diuretics act on the loop of Henle, on the thick ascending loop of Henle, and it blocks the sodium, potassium, and chlorine co-transporters, and that causes the gradient between the renal medulla and cortex to diminish and reduces the nephron's capacity to concentrate the urine, which leads to increased urination. That's how that diuretic works. And I hope this helps. Okay. But yeah, so loop diuretics are associated with the following metabolic imbalances, though. They're associated with hypokalemia, hypomagnesemia, hypocalcemia, hypochloremia, and hyponatremia and metabolic alkalosis. But the loop diuretics are like furosemide or torsemide. But even though it has those like gnarly effects, it is still the best diuretic. It is like the preferred choice of diuretics in patients with like symptomatic heart failure and CKD if their glomerular filtration rate is less than 30 mils per minute. Oh God. Why is my chat box so fucking big? That was not necessary. That was not intended. What the fuck? How did this happen? Huh? Yeah, it's supposed to be right there. What the fuck? That's weird. That's suspicious. I was not expecting that to happen. But yeah, I am also thinking that maybe I should just take the fucking plunge and make a Discord. Because, like, how else am I gonna put in all these pictures that I keep using on stream? Also, yeah, ad break. I appreciate if you guys stick by. If you don't, that's a-okay. But if you do, thank you. But okay, so for now we're gonna go back to like the calcium channel blockers. So we actually went through them on Monday. Like when we watched the sketchy on the calcium channel blockers. But if we want, we can play that video again because it's great. So the calcium channel blockers, there are two types of calcium channel blockers here. So we have the dihydropyridine calcium channel blockers. So like the ones that end in pene. So amlodipine, nifedipine. You probably know classmates that are on these medications, especially if they're a little bit older, or if they didn't really take care of themselves when they were younger. Or if they also just have like primary hypertension because of like family history, and then like it gets worse because of like, you know, you're young, you make choices, that kind of thing. It is also like the preferred medication in patients with isolated systolic hypertension. But dihydropyridine calcium channel blockers, the way that they act is, I'm also just gonna like write this out. So there, what was I saying? So there are three main classes of calcium channel blockers. There's the phenylalkylamine, so the verapamils. There's benzothiazepines, diltiazem, and dihydropyridine, so like nifedipine and amlodipine. Many are used to treat like, they're all used for, they're like a shit ton of these are used to treat hypertension and coronary artery disease and cardiac arrhythmias. Diltiazem specifically is poggers for cardiac arrhythmias. However, diltiazem and verapamil are less commonly used. The first-line medications for primary hypertension are the thiazides, the ACEs, the ARBs, and the dihydropyridine CCBs. However, you do not prescribe an ACE and an ARB together or in combination with a direct renin inhibitor. This increases the risk of hyperkalemia and renal dysfunction and does not provide additional benefit. No, don't do that. Don't do that, please. Please, please. I know most of... Please, no. Please, no. I'll cry. But okay, now we're going to go on to the second lines. Okay, but yeah, I am gonna go on to the second lines. What the fuck? Apparently I have small dishes I can do. I'm not looking at that right now. But okay, so second lines. These are the first line though. Okay, I'm gonna take this and I'm gonna select it. And I'm gonna, yep, I'm gonna copy that, paste, minimize it, and delete it. There. So, what was I talking about? Right. So second lines now. So these are going to be your beta blockers. So like your LOLs, your loop diuretics. Oh my god. Come on. Jesus Christ. Tablet, please. So your beta blockers are going to be the ones that end in lull. You have the combined alpha and beta. You have the non-cardio selective and the cardio selective. So we have the... You have the alpha and beta lulls. You have the so the alpha and beta adrenergic receptor antagonists. These are your carvedilol and your labetalol. So they mainly have they're non-selective, so they have both beta and alpha effects. So basically, for carvedilol and labetalol, the mechanism of action of these motherfuckers is that, let me just say it, 1 second. So, the mechanism of action for labetalol, I'm just going to use labetalol as an example because that's like the first thing I could think of that I could remember. So, labetalol, the way that motherfucker works is, since it is non-selective, for both, this is non-selective for both alpha and beta, the way that motherfucker works is that, it non-selectively antagonizes beta adrenergic receptors, but labetalol also selectively antagonizes alpha-1 adrenergic receptors. Following oral administration, labetalol has 3 times the beta blocking ability than the alpha blocking ability. And this increases like following IV administration. We already kind of know what like alpha-1 adrenergic receptor blocking does, so that's going to lead to vasodilation and decrease vascular resistance, which then leads to a decrease in blood pressure that is most pronounced while standing. So you may have, because I mentioned that, you may be seeing some, you might see some, but I think you're going to be seeing some positional hypotension, I think. I don't remember for sure. I think so. I don't remember right now. I think I'm right, though. I'm going to double check later. But yeah, like, if I double check later and I find out I'm wrong, then I'll just make some corrections on tomorrow's stream. But now we're going to go on to the non-cardio selective. So the non-cardio selective, these are still going to be beta blockers, but they do not have intrinsic sympathomimetic ability. Well, nadolol specifically has no intrinsic sympathomimetic ability, activity. So it's going to just block out beta 1 and beta 2, but not. So, 1 minute. Oh my god. Tablet, please. Please work. Please work. There we go. Ah! My god. You can literally see my tablet stuttering. Oh my lord. This tablet is gonna be the death of me. Ah. And also, you are absolutely correct. I wish my tablet was like cooperating with me. You literally can see I know how to write. Right now it looks like I'm drunk, but I'm not even drunk. I wish I could drink alcohol right now, but I can't. Oh my god. Well, I'm just gonna yap. Fuck this. Okay. But now we're gonna go into the non-cardio selective. So the non-cardio selective, this is still gonna be a beta blocker, but it's gonna be on beta 1 and beta 2. But it's gonna work on both like peripheral, but also like the heart as well. While the cardio selective is literally in the fucking name. It means it mainly works on the heart versus like everything else. It's not really gonna be on the peripheral vascular. It's gonna be on the heart. The cardioselective ones are atenolol. It's going to be bisoprolol or metoprolol. Metoprolol is a selective B1. Atenolol, like the cardioselectives are going to be B1 receptor antagonists. And they're used to treat hypertension, angina pectoris, and prevent future infarction and improve overall survival. It's also used as a rate control med for AFib. Adverse effects are going to include hypotension, bradycardia, depression, insomnia, dizziness, bronchospasm, and sexual dysfunction. So beta blockers are recommended for first-line use in patients with the following comorbidities. So we like them for when they have ischemic heart disease, history of heart failure, AFib, thoracic aortic dissection or thoracic aortic aneurysm, thyrotoxicosis, migraine, or essential tremor. Now, I already kind of mentioned on the loop. Now that we already talked about the beta blockers, I think we're going to move on to the loop diuretics unless like anybody has any violent reactions. Everybody good? I feel like everybody's good. I'm gonna hope everybody's good because like I'm gonna move on. But obviously, if we're not good, just let me know. I do look at the chat. Unlike our teachers. Honestly, our teachers should learn how to stream. Our teachers should learn how to stream. That's my hot take for the day. But okay, loop diuretics. I already showed you all the picture for it, but that's going to be furosemide and torsemide, and these are the preferred choice of diuretic in patients with heart failure and CKD. But we also have different kinds of diuretics on board that we could use. We have the potassium-sparing diuretics, so like the aldosterone antagonists or the epithelial sodium channel blockers. But first we're going to go into aldosterone antagonists. So aldosterone is a steroidal. It antagonizes a steroid, or it antagonizes hormones. So these two are the two that are steroidal are spironolactone or eplerenone, and the non-steroidal one is finerenone. And this is the preferred choice of diuretics with these are preferred choice in hypertension due to primary hyperaldosteronism. So if you have a fucked up amount of aldosterone, this is where you're going to be using your aldosterone antagonist. It's like it's literally right there in the name. If you have hyperaldosteronism, you fix it with an aldosterone antagonist. We love that. And the non-steroidal finerenone is also used as well. And these are usually frequently used as an add-on therapy in resistant hypertension. So, yeah. So I don't remember. I don't know like what they add on to, but like I just know that they're used as an add-on. Honestly, one of y'all might know. I'm just gonna hope that like one of the one of the senior med students actually comes into the chat at some point and helps me, or helps us rather, with that. I think Mocha like stop. I think Mocha's in neuro though, so she might not be joining. But yeah, so the next one is gonna be epithelial sodium channel blocker. So amyloride, amy, amyloride, or triamterene. These two are the way that epithelial sodium channel blockers work is, come on, come on. I don't remember how they work now. So like triamterene, like triamterene, these are selective for the oh right. Oh my god, I should have thought about it more. These are motherfuckers that are selective for the epithelial sodium channel. So like triamterene, benzamyl, amyloride. The only thing I know about like triamterene is the fact that like it's usually used in conjunction with hydrochlorothiazide. Like there's a medication that is a combination already of triamterene and hydrochlorothiazide because it's usually considered as an add-on therapy for patients with hypokalemia who are already receiving thiazides. So if you're already receiving thiazides and you're going to be putting them on an epithelial sodium channel blocker, you can just put the two together. No one's telling you not to. No one's telling you not to. You can. That's a-okay. Next, we're gonna go on to direct renin inhibitors. So like aliskiren, aliskiren, and it's rarely used. Low-key. It's rarely used. What? Huh? What up? Oh, for FCM? No. No. We already finished our assignment. Like, we finished that shit back in October. And honestly, we could have gotten it done earlier if I just remembered. Yes! Absolutely. We can. And so the direct renin inhibitor, so aliskiren, this is rarely used. It literally just directly inhibits renin on the RAS system. Then we have alpha-1 blockers, so prazosin and doxazosin. So it selectively inhibits, it selectively acts as an antagonist on alpha-1 adrenoreceptors and induces relaxation of blood vessels, as well as the smooth muscle cells of the bladder, neck, and urethra. It's used to treat hypertension. Doxazosin is used to treat hypertension, while tamsulosin and alfuzosin, those are used to treat BPH or benign prostatic hyperplasia. Prazosin and doxazosin are used as for heart. The other ones are not. Prazosin and doxazosin, these are used in hypertension caused by pheochromocytoma, but it can also be used as an adjunct for patients that are already dealing with like benign prostatic hypertrophy. And then we also have the alpha-2 agonists. So unlike the alpha-1 blockers, where they're trying to inhibit the action of alpha-1, alpha-2 agonists are trying to make your alpha-2 fuckers work even harder. So when you activate the alpha-2 receptors in like the presynaptic sympathetic neurons of the central nervous system, that leads to a decrease in sympathetic tone that causes vasodilation and lowers blood pressure. Adverse effects include orthostatic hypotension, sedation, and bradycardia. And these medications are going to be methyldopa and clonidine. These are rarely used though. Just keep that in mind. But yeah, so that's the main thing. These are rarely used. But I mean, it's an option. But yeah, those are options. But the last option we have that's a second line is the what's it called? The direct arteriolar vasodilator. So these are going to be minoxidil and hydralazine. Minoxidil, you probably already know about this medication for the use in like increasing hair growth. Yeah, yeah. It was initially found, it was like initially invented to like work to like address severe refractory hypertension, but then like we had the added side effect of increasing hair growth. It increased the I think it increased the like anagen phase of hair growth, if I remember correctly. I think it increased the anagen phase, like the new growth phase of hair growth. Because it's also a direct arterial vasodilator, and it's also a first-line treatment for men and women. Also, I'm pretty sure you can also use, well, no, pulmonary hypertension, you're going to be using sildenafil. But hydralazine is the best, is like, it is a treatment option for pregnant patients. Because pregnant people can't really use much. Low key, because like a lot of these medications are contraindicated for the young and for the pregnant. Pregnant people can't have shit in this society, especially medications. They can't have fun. I'm joking. They can have fun, I guess. I don't know. I'm just talking right now. But yeah, so here are some like important things though for pharmacological management for hypertension. Patients with CKD, or if they have a baseline potassium that's greater than 5.5, and those that take potassium supplements or potassium sparing drugs. So potassium sparing drugs can be like fucking, I think it's gonna be spironolactone is a potassium sparing diuretic. Yeah, it's literally a potassium sparing diuretic. Those motherfuckers are those patients are at higher risk of hyperkalemia as an adverse effect from pharmacological treatment for hypertension. And you do not abruptly discontinue beta blockers or alpha 2 agonists. You need to taper them off, or else y'all already know what's gonna happen. Rebound hypertension. We don't like that shit. That shit's gnarly. No, please. But so like, if I were gonna go in, I kind of just went through a basically brief overview of like all of them, of like the first line and second line medications for hypertension. But if we were gonna go separate these motherfuckers based on like the patient's comorbidities, I need to like delete that, and I hope, yes, it's working. I'm gonna crash out. What? What the fuck? Come on. Let me delete. I hate my tablet. Come on, please. Please work. I'm gonna cry. I guess in addition to a but yeah counter, I need a tablet malfunction counter. Fucking hell. Okay, are you working now? Okay, for the most part. So, oh my god. Okay. Does that look like comorbidity to you guys? Does this look like comorbidity? Legit. I I I just need to ask. Do you know what I fucking wrote? I hate this. It said something. I don't know what it's supposed to say, but it's supposed to be saying something. There we go. There we fucking go. Oh my god, no. You cannot keep doing this. Oh my god. Oh my god. How do I remove this ruler again? But okay. Back to this. So by comorbidity, I already kind of mentioned a lot of these. So how do I remove the ruler? How do I move the ruler? Okay. For CKD, we're gonna be like initially giving them ACE inhibitors or ARBs, and then the treatment goal is gonna be like to get their systolic blood pressure less than 120. So I feel I'm gonna like look for some questions to like run us through for this really quick after. So oh my god. Come on. ACE I plus ARB. Okay, so ACE inhibitors is going to be like initially ACE. So for CKD, it's going to be initially an ACE inhibitor or an ARB. And then the TX goal less than 120 for SBP. That's for that one. Next, for diabetes, if... Okay. There we go. I think I kind of figured out, like, what the issue was. So, the way that I have my tablet all set up, my left hand kind of blocks the sensor, the Bluetooth sensor for my tablet. So, if I keep blocking the sensor for my tablet, then obviously my tablet's gonna have some delays and lag. It's better now. It's better now. I am so silly. At least I figured it out though. So for diabetes, what we are gonna be giving them is for DM. Oh my god, come on. For DM, for microalbuminuria and proteinuria, you're going to be still putting them on an ACE or an ARB. Why? ACE or an ARB. The reason why we're doing that is because these medications are nephroprotective and can, it can, like, prevent further damage, basically. So, basically, ACE inhibitors, they are nephroprotective, I already mentioned, and they are poggers for patients with diabetes. So, basically, like, these medications are awesome for this because, it can like prevent further damage to the kidneys of the patient of these diabetics. This is extremely important. We don't want them to get fucky kidneys because like their blood pressure is already making their kidneys fucky enough, low key. But yeah, so now we keep going. I am going to crash out. Okay, come on. Okay. Perfect. Amazing. My pen tablet fucking works. Okay, and for patients without like proteinuria or microalbuminuria, you can put them on any first line agent. So like still ACEs, ARBs, or you can still like mainly ACEs or ARBs, but you can also put them on a calcium channel blocker or even a thiazide. The treatment goal is going to be getting them less than like 130/80. But for CHF, so though I actually don't know how much this is followed. According to the American Diabetes Association diabetes guidelines from 2017, they have a looser recommendation of like less than 140/90, with like possibly lower targets for patients with for patients that have a higher like cardiovascular risk. But now CHF is the fucking one. So for CHF, so there's two different kinds of like congestive heart failure. So heart HF or EF. So basically heart failure with reduced ejection fraction. So your heart failure with like a reduced stroke volume and reduced like left ventricular ejection fraction. So like LVEF less than 40%. So you're going to be needing a little bit of some medication, obviously. So remember how we mentioned like beta blockers are like are like recommended for use in compensated congestive heart failure. They must also be used cautiously in decompensated heart failure, but they are also contraindicated in cardiogenic shock. So for the CHF, this is going to be beta blockers, diuretics. So like your aldosterone antagonist, spironolactone can be used. ACE/ARB. ACEs and ARBs. So for reduced ejection fraction, you can put them on a cardio, you can put them on a beta blocker, you can put them on a diuretic, you can put them on an ACE or an ARB, or you can put them on an angiotensin receptor neprilysin inhibitor, though I don't really know how often that's used. I feel like I'm gonna have to ask Psychic about that. Like, though also, the ARNIs, the angiotensin receptor neprilysin inhibitor, should not be used in combination with ACE inhibitors because of an associated elevated risk of angioedema. Don't do it. It's bad. But the goal for like this one is still gonna be getting them less than 130/80. For preserved ejection fraction, though, to address their current volume overload, put them on diuretics. So LVEF greater than or equal to 40%. This is going to be diuretics. If fluid overload. Oh god. No! Okay, wait. For fluid overload, diuretics. Without fluid overload, ACE/ARBs plus a beta blocker. ACE or ARB, that's why there's that little slash there, plus beta, plus like where's my beta sign? Beta plus BB. So ACE or ARB plus BB, and no nitrates. No nitrates. Treatment goal is still the same. Okay. I realize I can just do Control Z instead of like having to struggle with my fucking tablet all the time. Though it means I have to click a shit ton. So we're just gonna have to deal with that. Next one is gonna be asthma. If you have asthma, do not use beta blockers unless unless like it's necessary, because like non-cardioselective beta blockers can cause bronchoconstriction, which is, obviously the bad part with asthma. You want, because like they bronchoconstrict all the time. You want them to not bronchoconstrict, obviously. Wait. Wait, what the fuck? What? But yeah, sorry. I just thought I saw someone in the. I thought I saw a name in the chat that I got freaked out by. I was like, huh? I am being perceived? What the hell? But okay, so for asthma, the initial therapies, you're going to be in ARBs, calcium channel blockers, or maybe a thiazide. Like, there's no real preference unless like it's really up to them. I feel like there's more scientific ways to talk about that. I feel like it's up to the patient, though I really don't know. I'm gonna have to like look that up and find out. If you have asthma, the treatments for hypertension, well, so like there's conflicting data, but like the general one is lifestyle changes, but also lifestyle changes plus no beta blockers. No beta blockers, definitely no non-cardioselective beta blockers. If there's an indication for cardioselective beta blockers, like if they can't tolerate ARBs or CCBs or thiazide diuretics, okay, but like, no. Oh, never mind. I figured it out. So for ARBs are preferred over ACE inhibitors because you can have an ACE inhibitor-induced cough, which is bad. You don't really, and like, there were some evidence suggesting like increased asthma severity with patients on ACE inhibitors, so I don't really know that for sure. I'd have to like read more of that study. I would have to look it up further. But okay, the next one, if you have gout's a big one. Oh wait, I should like really highlight. Non-CBB. No non-cardioselective beta blockers. You are going to fuck up their asthma. Next one is migraines. Beta blockers or CCB. Because like I was actually put on CCB, but it was just for migraines, not for hypertension. I didn't have any hypertension problems. They thought I did, but I don't, thankfully. But yeah, that's what we really use there. And then for gout, gout. Yeah, I forgot about gout. Fuck. For gout, what we're going to be using is an ARB. ARBs, ACEs, or CCB. Gout, it's going to be ARBs, ACE inhibitors, or CCBs. No thiazides, because it'll increase your uric acid levels. So obviously we don't want that. But for osteoporosis, the initial therapy will be thiazides, because if you decrease your renal calcium excretion, you're going to have reduced bone loss. Crazy. Isn't it fucking awesome? Oh, also, important thing, beta blockers can mask symptoms of hypoglycemia in patients with diabetes mellitus. For special patient groups, so like if you're a child, you're an elderly adult, or a pregnant patient, pregnant patients, it's going to be, let me see. Let me see, you guys. Let me see. I don't remember right now. Oh my god. Damn it. So for hypertensive pregnancy disorders, the management is just going to be like It depends on the gestational age of the like fetus, low key. But I mean, you can still use hydralazine. Or what is it? It's not hydralazine. Fuck, I said the wrong word. The word for that one is, it is the, oh, it is hydralazine. But for pregnant people, you can use hydralazine. It's a treatment option for pregnant patients. I mean, it's not like we have anything else, really, low-key. So, hopefully we kind of got what we were doing there. Hopefully we understand what's going on. We are gonna go and do some questions. So give me 2 seconds while I set that up. I need to set that up for y'all. We're gonna do some hypertension questions. We only have 7. So give me 2 seconds to set this up, and 3, 2, 1. Okay. I'm gonna make myself a little smaller. That way it's a little bit easier to see. Oh god. I did not mean to rotate myself though. That was not intentional. But okay. So, how is this for y'all? Are you able to see the question? Is it visible? I hope so. So, 48-year-old woman comes to the physician for the evaluation of 24-hour blood pressure monitoring results. Over the last 3 months, she had intermittent nausea, decreased appetite, and increasing weakness and fatigue during the day. She was treated twice for kidney stones within the past year. Her current meds include lisinopril, amlodipine, and furosemide. Her BMI is 31. Her blood pressure is 152/98. So, what are we looking at here, you guys? Would we say this is resistant hypertension or not resistant hypertension? And tell me why. Come on. Because, like, for me, when I look at this, we already see she's 48-year-old woman. And we see the result of 24-hour blood pressure monitoring results. She has had intermittent nausea, decreased appetite, and increased weakness and fatigue during the day. So, it's giving it endocrine for me. She's been treated twice for kidney stones within the past year. She's already on 3 BP meds. She's on April, she's on Apine, and she's on fucking furosemide. She's on a loop diuretic. Yeah, that's a loop diuretic, right? Yeah, no, wait. Am I gaslighting myself now? I think I'm gaslighting myself now. Oh my god. Yeah, it is a loop furosemide is a loop diuretic because it's Lasix. Oh my god. So, she weighs 97 kilograms, her BMI is 31, her blood pressure is resistant! So obviously she has resistant hypertension. A 24-hour blood pressure monitoring indicates elevated nocturnal blood pressure. For further evaluation is most likely going to show which of the following. Because there's elevated nocturnal blood pressure, that means she doesn't have the dip. She doesn't have that dip that we see. Remember how I mentioned that, like, when you're asleep, usually your blood pressure is going to dip by like 10%? People with OSA aren't going to be seeing that dip. So, what I would be expecting is, like, I mean, her sodium looks a little high, but wait, let me look. Her sodium is fine. Yeah, her sodium is fine. Her chloride is okay. It's like 101. Like, her sodium is like borderline high, but it's not like 146 and above. It's not like pushing it for me. And then we have her chloride here. Her chloride is only like 101. That's okay. Her potassium is still normal. It's within normal limits at 4.5. Her bicarb is okay. It's still within normal limits. Literally nothing in these labs are telling me anything I want to look out for. So, because these labs ain't telling me shit, I'm gonna go back and look at the results here. I'm gonna look back at the question. So, she's 178 centimeters tall. She weighs 97 kilograms. Her BMI is 31. And because there's elevated nocturnal blood pressure, to me, instead of like thinking this was endocrine, because I was thinking maybe the kidney stones would be important, this is giving OSA. So for me, I would say that we would be expecting decreased nocturnal O2 sat. What? Really? Oh. Oh my god, the OSA was the red herring. Shit. Oh my god. I got cooked by that. Okay. Increased primary hyperparathyroidism. Damn, that question cooked me. Oh my god, that's spooky. I was not expecting that. Yeah, aldosterone to renin isn't gonna make sense because that would be Conn syndrome. Conn syndrome doesn't have the hypokalemia. Yeah, everything else looks really normal. Oh my god, it's the calcium! The calcium I didn't see! I didn't look at it! I looked at everything else and thought it was normal! I didn't see the calcium! I didn't see the calcium! Fuck! I'm cooked, y'all. I'm fucking cooked. Okay, so, next one. Oh, decreased urination. She denies dysuria, fevers, or chills. Her blood pressure is 133/67. Physical exam shows no abnormalities. Compared to measure... Oh. Increase systolic flow. I'm pretty sure this is going to be an allopro's fault. This could be an allopro's fault. I was like, everything else, these are diuretics. Wait, actually. One out. Yep, I was right. I was fucking right. Okay. ACE inhibitors like enalapril inhibit efferent arterial constriction, which leads to a decrease in GFR and acute kidney injury, as seen here. Patients with bilateral renal artery stenosis are especially susceptible to this effect, as the kidneys rely on efferent arterial constriction to maintain the GFR. Angiotensin II receptor blockers, so ARBs, work in a similar fashion. So ARBs and ACE inhibitors are contraindicated in patients with bilateral renal stenosis. LOLs didn't make sense here to me. Because, like, LOLs don't have any effect. That doesn't make any sense. Everything else would have an effect. It doesn't augment the ability of renin. Spironolactone acts on distal convoluted tubules, and it doesn't reduce GFR or renin. Hydrochlorothiazide isn't going to be another option here either. It doesn't make any fucking sense. But yeah, it's enalapril. Let's go. Okay. Coronary artery disease and hypertension follow-up exam. Oh. No abnormalities. Renal duplex shows 90% occlusion of the right renal artery. Oh. Cause which of the following? Yeah, his blood pressure is crazy though. Oh my god. So because the physical exam shows no other abnormalities, but the renal duplex shows 90% occlusion of the right renal artery, decreased renal blood flow is most likely to cause which of the following? So... I mean... decreased renal blood flow is gonna cause, like, hyperplasia. It's gonna cause hyperplasia to compensate for the arterial stenosis, or the renal artery stenosis. You're going to be compensating for that with hyperplasia of the juxtaglomerular cells. Honestly, I'm glad I'm doing these questions because, like, even though I may have answered them in the past, do I remember them? No. No, I don't. It's like I'm seeing these questions again for the first time. Okay, a 55-year-old patient with hypertension, hyperlipidemia, type 2 DM, and asthma comes to the physician because of a 2-month history of intermittent dry hacking cough. Dry hacking cough? Ayo. 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 No, I'm gonna send these over to the group chat. So, he has asthma and he's on Ramipril. What do we think here? To me, I feel like the best option would be to stop the patient on Ramipril and then start him on something else. He could go on Ramipril isn't gonna make sense. Change him from Ramipril to a sartan or something else. Because, like, simvastatin isn't gonna do shit. Because, like, it's not the simvastatin that's causing the cough. Because he's here because of a 2-month history of intermittent dry hacking cough. He has no fever, chest pain, or shortness of breath, which could explain the cough. It's all the Ramipril. We can put him on an ARB instead. ACE inhibitors are dry cough is a characteristic side effect of angiotensin converting enzyme inhibitors because they decrease blood pressure by inhibiting the RAS system. However, inhibition of RAS also causes an increase in bradykinin, which leads to bronchoconstriction and dry cough. And the dry cough, like, ACE inhibitors have been noted to, apparently, like, have been noted to worsen asthma in patients that have asthma and have hypertension. Okay. I'm also going to screenshot this and send this to the group as well. Yeah, I feel like I do have to make a Discord at some point. Ugh. Like, I already made one for my batch of classmates, but I'm going to reset this and reset all the highlighting and send this over to my group. I know I got this wrong. This is just to see if they catch it. But okay, I know the answer is not nocturnal oxygen saturation. That was the red herring and I got caught by it. But yeah, so I got this right. Yay. I'm gonna reset it and then take a screenshot of that as well. Oh my god. Okay. So, renal duplex and ultrasonography. I already did this one. Hyperplasia of the JG cells to compensate for the renal stenosis. Because, like, that's gonna fuck it up more, obviously. Ramipril and sartan. Cool. Now we have an otherwise healthy 65-year-old for a follow-up visit for elevated blood pressure. Thyroid function, serum electrolytes, and serum creatinine are the normal levels. Oh, this is medicine-induced. Yeah, he took a decongestant. This is medicine-induced vasoconstriction. What? When did he take the med? Oh my god, 4 weeks ago. I got caught by it again. I'm gonna cry. Arturo. Oh my god, he's 65 years old. I got caught by it again. Damn it. I keep getting caught by these pitfalls. What the hell am I supposed to do? I know better. I know better. How dare this happen to me? Ah! I'm gonna baby rage about it. I'm gonna baby rage about this. Jesus fucking Christ. Ah! Ah! I'm annoyed. Urgh. Here we go. New question. 28 years old, or 20 years old. I can't read. Oh my god, wait. That should be better. Reason for visit? So, he has a scheduled pre-season physical exam. Headache after partying hard at a college frat party. 10 beers on the weekend? Okay. I'm not judging. Damn. What it's like to be young. My god. God, I remember being young like... Oh no, I'm gonna sound old. But like, I remember being young like that. There were times where I could like drink until like fucking 5 a.m. and then still come to class like back in college and then do great. Like, do great on exams. Obviously, don't be like don't do what I did. Don't follow my example. However, it was never it, you know. Now if I drink like maybe 3 drinks on a night, there's like a 70-30 chance that I get a exacerbation of my migraines and like exacerbation of my migraines, and then like I'm just hungover and I'm non-functional for the next day. It's crazy. God. I wish I were... Oh my god. I feel so old. I feel so old. Oh my god. Oh my goodness. But okay, so man drinks a shit ton. He smokes ciggies like... He smoked half a pack of ciggies daily for 2 years, so how many pack years is that? So that means 0.5 times 2. So it's just 1 year. He just smokes cigs for like 1 pack year, basically. Like, I think I did the math right on that. Somebody can correct me on that, I'm pretty sure. Because, like, pack years is like, how many packs per day that you smoke times the amount of years you have smoked. So, if you only smoke half a pack a year, half a pack a day, and you've only smoked for 2 years, which, honestly, low-key, same. I did that too. I was a very wild college student. That's all I'm gonna say. I was a very crazy college student. I am not ashamed of that. Obviously, I have improved since then. I no longer do that because A, I like talking, and smoking is also... Nobody... Okay. Nobody really talks to you about, like, well, they do after, like, when you're deep in it. But, like, nobody really talks to you about, like, how expensive smoking is while you're doing it. Because, like, in college, I don't know, like... I did buy a pack, like, a few times, but, like, most of my time smoking, I was just bumming cigs off of my friends. And then we had a communal pack. God, I am revealing a lot about, like, my prior habits. Oh my lord. Yeah, don't be like me back in undergrad. Be like me in med school. Doing that less often. I mean, I don't smoke anymore, for one thing. But okay, so... Yeah, his blood pressure is crazy. Hasn't really changed much after like 30 minutes rest. Gnarly. Okay. It's the alcohol intake. Like... Wait. Oh! His blood pressure was normal at his last 6-month visit. I see. Yeah, if you drink a shit ton, obviously your blood pressure is gonna be crazy. Obviously your blood pressure is gonna be fucking crazy. Where... Oh, I didn't read that. I didn't see that in the past medical history because it's not usually in there. But yeah, oh my god. Damn. Let's go. I'm not terrible. So, 69-year-old man, nice, comes to the physician for a follow-up examination after an in-office blood pressure reading of 139/86. Oh! He's 69 years old. He has type 2 diabetes. I think I'd be okay to put him on a loop diuretic. That would be my first thought. Like, legitimately, this looks like the possibility for me. Because he has no left ventricular hypertrophy or other abnormalities. Well, yeah, I think that's fine. Also because, like, I don't really want to put him on, like, I don't want to put him on a beta blocker because, like, with the hypotension risk, and he's 69, like, that makes him a fall risk. I don't know if they even, like, consider that in the questions, but that would be my argument as to why I'm not going to put him on carvedilol. I kind of just want to put him on a furosemide. Really? Oh, okay. My second... Oh, okay. Yeah, that's fine. Yeah. I was, like, tied between a loop diuretic or lisinopril. Carvedilol also has, like, the issues, is also because, like, beta blockers are not recommended as first line unless indicated for a significant cardiac condition. They can also, beta blockers can also mess with symptoms of hypoglycemia, and beta blockers are less effective at preventing cardiovascular events. So yeah, their beta blockers are still second line. Okay, could be worse. But yeah, this is... Okay, cool. Alright. Oh! Okay, I'm gonna pull up the Anki for this as well, because I think that'd be a good idea. I'm gonna pull up the Anki for this as well, because this is gonna be interesting. Alright, Cubake session. Oh! Oh, let's go. Okay, cool. Let's go. It worked. Hey, more blood pressure questions. Let's go. Awesome. Okay. But okay, 70-year-old man comes to the physician for worsening nocturia, fatigue, shortness of breath, and exertion. While he used to be able to walk for 15 minutes at a time, he now has to pause every 5 minutes. And recently he started adding 2 pillows to avoid waking up short of breath at night. So what do we think that is, y'all? So to me that looks like positive orthopnea. He's having issues lying down and sleep and breathing. So he has to have 2 pillows to sit, like, basically sleep a little further upright so he can breathe. His pulse is, pitting edema. He has CHF. Maybe he has, so he definitely has CHF. That is what I can see. That is, like, the obvious thing that comes out to that's the obvious thing that, like, pops out to me. Like, oh, yeah, nah, you're concerning, buddy. You're definitely concerning. Oh god, I didn't realize this. Okay, that's cool. At least my reading works. Thank you. Thank you, Cybernetic Flora. You're so cool. I mean, you are cool for like sticking with this damn stream like nearly daily, like whenever I stream. But okay, so decrease in total peripheral vascular resistance. Decrease. Oh, potassium retention doesn't make sense here. It's gonna be this one. Oh wait, no. What is it? I am gonna scream. Reduced cardiac output is an organ hypoperfusion. Okay. As for gallop by basilar rouse. I am so pissed. I literally got the diagnosis right, but I got the fucking question wrong. That happens to me a lot, by the way. Okay. Okay, I'm gonna copy this Anki query so that I can like pull it up later. But okay, so type 2 DM treated with metformin. Blood pressure is really high at 162/96. Her albumin creatinine ratio is greater than 40. Normal is less than 30, so it's a little high. Treatment with enalapril is initiated. Patient develops a dry cough. Drug is discontinued. The patient is subsequently put on a new antihypertensive. So, it's going to be increased urine sodium, decreased referral resistance, probably decreased renin, decreased angiotensin, decreased aldosterone, so probably B. Oh no. It's E. Okay. Damn it. Oh no! That said okay, yeah, no, it was E. Oh well, that's fine. I was like tied between E and B this whole time. Damn it. Routine HME. Felt well except for occasional headaches. Ooh, yikers! So this is gonna be abdominal bruit because like that's gonna be atrophy of the kidney. Because abdominal bruit of renal artery stenosis is continuous because it occurs during diastole and systole. And it can be auscultated over the costovertebral angles of the flank and or epigastrium. And it is 2 to 3 centimeters lateral to the midline. I kind of want to look at a thingy of this. I wonder if there's a video of it. Is there a video of like hearing it? I guess not. Unfortunate. Okay. Cool. Next one. Otherwise healthy 65-year-old comes to the physician for follow-up visit for elevated blood pressure. 3 weeks ago, his blood pressure was 160/80. Subsequent home blood pressure readings at day 5, 10, and 15 were found. Oh, God. 4 weeks ago. Yeah, he's 65 years old. I'm not getting this again. I am not getting caught out like that again. I am not getting caught by red herrings. Because this shit pisses me off. Okay. 64-year-old man with coronary artery disease and hypertension comes to the physician for a follow-up examination. 160 to 150, so it's like wide pulse pressures. 3 weeks ago, he started on amlodipine. Duplex with it. Okay, 90% occlusion. Decreased renal blood flow is going to increase and lead to like It's going to lead to a compensatory mechanism. Leading to hyperplasia of the JG cells. I will not forget this again. I am not going to forget this again. 57-year-old comes with wrinkles. Oh. What? Huh? I don't know what this is. I don't know, maybe decrease in cross-linking of age-related. Oh, it was just elastin. Okay. Sorry, I don't know aging yet. I haven't gotten there yet. I am not old yet. I'll know about aging when I get there. Okay. Brought to the physician by her friend who was worried because the patient has appeared increasingly distressed. Oh right, I forgot to go get my Twitch alerts. Copy browser source. I'm gonna increase. I'm gonna do something really quick. Don't mind me. Oh Jesus Christ, sorry about that, y'all. Accidental. I promise. Okay, what was I doing? How did I forget already? Oh my god. There we go. This should be working now. Okay, cool. Okay, so esomeprazole. So she's on omeprazole. Her serum creatinine and urea BUN were her BUN was in reference range. Subperiosteal thinning of the phalanges and several. Oh. Increased serum calcium. Increased PTH. Decreased A. It's A. Stones, bones, groans, and psychiatric overtones. Primary hyperparathyroidism. Fucking got it. Let's go. She's appeared increasingly depressed. Okay. Evaluation 24-hour blood pressure monitoring results over the last 3 months. She had intermittent nausea, decreased appetite, and increased weakness and fatigue during the day. Treated twice for kidney stones within the past year. I am not getting this wrong again. Knowing me, I'm gonna get this wrong again, Loki. Kidney stones for the past year. Okay, I see now. I see what they're edging me towards. I didn't see... I thought this was what I was worried about. I got hit by the... trap. Honestly, I kind of just want to ask, like, how do I... Got you. I understand now. But, okay. So, yeah, this is increased serum parathyroid hormone. Ooh! Ooh! I feel like this is gonna be vasoconstriction of the kidney. Like renal vasoconstriction. So it's probably gonna be decreased something excretion. Decreased proton excretion. Really? RAS. Oh. Oh my god, I was thinking of the wrong one. Proton, I was thinking of sodium. I was like decreased sodium excretion. That's obviously what it is, right? Close, but no fucking cigar. I was like, oh. RAS. I was trying to think of like what's gonna decrease like excretion. Sodium is gonna be resorbed. Fuck. Oh well. I could be wrong. I keep getting careless mistakes. Okay. Intermittent dry cough. We're gonna stop him one. We're gonna stop the lisinopril first, like or Ramipro. Candesartan instead. We can put him on an ARB. We can put him on an ARB. Or yeah, because cough is rare. Ooh, wait. Oh, depression. This is gonna be like a thyroid thing. Is this not hypercalcemia? Oh my god, I don't know how to read. Let me look at that again. Parafollicular. I didn't read it fully. I thought it said parathyroid gland. I thought it said parathyroid gland. I'm keeping that because I knew what it fucking was. I just clicked the wrong thing because I didn't read the choice. They really should like allow you to like click on it, but then like give you a second to submit it. Low key. Oh, okay, man, daughter, wife, did you lie down? Ooh. Ooh, ooh, ooh. Hydrochlorothiazide. Hydrochlorothiazides plus lisinopril, you're gonna get first dose hypotension. That's why he's like really wobbly and weak. I was like, nothing else in this damn game makes sense. But okay, let's continue. 48-year-old man comes to the physician because of a 3-month history of fatigue, polyuria, and blurry vision. Ooh! Ooh, he's diabetic! But not too bad of a diabetic where he needs, like, insulin. I kind of want to put him on... I want to put him on an ARB to, like, prevent, yeah, it's gonna be an ARB. They're nephro... ARBs are nephro... ARBs are nephro... protective. We want that. We want that in this patient. Obviously. 69-year-old man with hypertension and congestive heart failure is brought to the emergency department because of a 9-day history of worsening shortness of breath and swelling of his legs. Rest speeds are 25 a minute. Blood pressure is 160/98. Pulse ox on 5 liters via nasal cannula shows a blood O2 sat of an O2 sat of 92. Pre-tibial edema. Ugh. Ooh. JG cells, I think. RAS? Isn't this... Is it? Oh my god, it's ACE. Okay, I thought ACE was plagued by JG cells. I was in the wrong part, because I was like, renin, angiotensin. Not the angiotensin. Oh well. 52-year-old man comes with a physician because of a 4-month history of fatigue, weakness, and constipation, decreased appetite, and intermittent flank pain. He takes ibuprofen for knee and shoulder pain. Ooh. Oh. It's probably like 25 to 125. Yeah. Primary hyperparathyroidism is going to be important here. Especially because of the parathyroid. Inhibition of... Oh, no, 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 no. Okay, well, yeah, I got this wrong. I just got this flat out wrong. I'm gonna look at my kidney physiology tomorrow, I guess. I don't remember anymore anyways. Okay. Acute severe pain in the middle of her lower back. Menses occur. Okay. Calcium is fine. Oh no, primary hyperparathyroidism, so... Oh, interleukin 1. Oh my god, interleukin 1 secretion in osteoblast, which does the osteoclast thing. Oh wow. Concentration of 9%, treatment in lisinopril. So... Oh no. It would be increased GFR. Oh no, what? Would it be decreased? Oh, okay. I don't know this one. When initiating a treatment with lisinopril, a modest reduction of GFR is typically seen within the first several days. Simultaneously, renal plasma flow is increased. I see. I always forget about this. We are... this is going to be tomorrow. This is definitely going to be a tomorrow thing. Facial swelling. Oh my god. Non-immunologic release of histamine. Oh wait, no! Oh, it's ACE. Oh right, because ACE inhibitors are going to cause that flushing. Damn it. Oh well. That's on me. That's on me, y'all. Okay. Worsening renal function. This is an alloprol. Yeah, this is renal artery stenosis, which gets worse in with ACE inhibitors. It could be fine. Yep, this means I'm doing this again tomorrow. Alrighty, so I think this is a good place to wrap up because tomorrow we're going to do this again. I'm going to go back to the schedule and we are going to review like just what we're going to be doing tomorrow. So today was Amboss, and basically we did Amboss and we talked about hypertensives. Basically I went through a lot of the patho and I went through a little bit of the patho. I also went through a little bit of the pharmacology. Honestly, we can do to go a little bit more in depth on that. And we're going to definitely do that tomorrow with the CVS patho. Then CVS viruses is going to be still Friday, Saturday, it's still going to be nothing. Next Sunday, there is going to be stuff going on. There will absolutely be stuff going on. Basically, on that day, what we'll be doing is... we will have this up. Don't mind me, I'm going to minimize that. I'm going to give you all a little preview of what's going to happen tomorrow. Basically, because like Saturday is going to be the big CVS review where we review everything we went through, like this week and past week, or this week and next week. Like, we are gonna be fucking tired of hypertension and heart shit by the end of these 2 weeks. We're gonna be done with it. It's gonna be great. I promise. And it's gonna be around this time again, 6 p.m. Philippine time or 5 a.m. EST. I don't know how to convert it to any other time zone. Don't expect that out of me. Alrighty. Hope y'all have a good day.